Hypothyroidism. Hypothyroidism is a deficiency of thyroid hormone that causes a general slowing of the metabolic rate. About 4% of the US population has mild hypothyroidism, with about 0.3% having more severe disease. Hypothyroidism is more common in women than men. Subclinical hypothyroidism occurs when the TSH is greater than 4.5, but the T4 levels are normal. Up to 10% of women older than 60 years have subclinical hypothyroidism. Patients with overt hypothyroidism have increased TSH and decreased T4 levels. Critically ill patients may present with non-thyroidal illness syndrome, NTIS. Those with NTIS have low T3, T4, and TSH levels. Etiology and pathophysiology. We classify hypothyroidism as primary or secondary. Primary hypothyroidism is caused by destruction of thyroid tissue or defective hormone synthesis. Secondary hypothyroidism is caused by pituitary disease with decreased TSH secretion or hypothalamic dysfunction with decreased thyrotropin releasing hormone (TRH) secretion. Hypothyroidism can be brief and related to thyroiditis or stopping thyroid hormone therapy. Iodine deficiency is the most common cause of hypothyroidism worldwide. In the United States, the most common cause of primary hypothyroidism is atrophy of the thyroid gland. This atrophy is the result of Hashimoto's thyroiditis or Graves' disease. These autoimmune diseases destroy the thyroid gland. Hypothyroidism can develop after treatment for hyperthyroidism, specifically thyroidectomy or RAI therapy. Drugs such as amiodarone, which contains iodine, and lithium, which blocks hormone production, can cause hypothyroidism. Hypothyroidism that develops in infancy, cretinism, results from thyroid hormone deficiencies during fetal or early neonatal life. All infants in the United States are screened for decreased thyroid function at birth. Clinical manifestations. The systemic effects of hypothyroidism are characterized by a slowing of body processes. Manifestations vary depending on the severity and the duration of thyroid deficiency and the patient's age at the onset of the deficiency. Symptoms may develop over months to years unless hypothyroidism occurs after a thyroidectomy, after thyroid ablation, or during treatment with antithyroid drugs. The patient is often tired and lethargic. There may be personality and mental changes, including impaired memory, slowed speech, decreased initiative, and somnolence. Many appear depressed. Weight gain is a result of a decreased metabolic rate. Hypothyroidism may cause significant cardiovascular problems, especially in a person with a history of CVD. It is associated with decreased cardiac contractility and decreased cardiac output. The patient may have low exercise tolerance and shortness of breath on exertion. High serum cholesterol and triglyceride levels and the accumulation of mucopolysaccharides in the intima of small blood vessels can result in coronary atherosclerosis. Anemia is common. Patients with severe long-standing hypothyroidism may have myxedema. Myxedema results from the accumulation of hydrophilic mucopolysaccharides in the dermis and other tissues. It alters the physical appearance of the skin and subcutaneous tissues with puffiness, facial and paraorbital edema, and a mask-like affect. Patients may have an altered self-image related to their disabilities and altered appearance. In the older adult, we may attribute the typical manifestations of hypothyroidism, fatigue, cold and dry skin, hoarseness, hair loss, constipation, cold intolerance, to normal aging. For this reason, the patient's symptoms may not raise suspicion of an underlying condition. Older adults who have confusion, lethargy, and depression should be evaluated for thyroid disease. Complications: the mental sluggishness, drowsiness, and lethargy of hypothyroidism may progress gradually or suddenly to a notable impairment of consciousness or coma. This situation, termed myxedema coma, is a medical emergency. Myxedema coma can be precipitated by infection, drugs, especially opioids, tranquilizers, and barbiturates, exposure to cold, and trauma. It is characterized by subnormal temperature, hypotension, and hypoventilation. Cardiovascular collapse can result from hypoventilation, hyponatremia, hypoglycemia, and lactic acidosis. For the patient to survive myxedema coma, vital functions must be supported and IV thyroid hormone replacement given. Diagnostic studies. The most reliable laboratory tests for thyroid function are TSH and free T4. These values, correlated with symptoms obtained from the history and physical examination, confirm the diagnosis of hypothyroidism. Serum TSH levels help determine the cause of hypothyroidism. Serum TSH is high when the defect is in the thyroid and low when it is in the pituitary or the hypothalamus. The presence of thyroid antibodies suggests an autoimmune origin. Other abnormal laboratory findings are high cholesterol and triglycerides, anemia, and increased creatine kinase. Interprofessional care. The treatment goal for a patient with hypothyroidism is to restore a euthyroid state as safely and rapidly as possible with hormone therapy. A low-calorie diet can promote weight loss or prevent weight gain. Levothyroxine Synthroid is the drug of choice to treat hypothyroidism. In the young and otherwise healthy patient, the maintenance replacement dosage is adjusted according to the patient's response and laboratory findings. When beginning thyroid hormone therapy, the first dosages are low to avoid increases in resting heart rate and BP. In the patient with compromised cardiac status, careful monitoring is needed when starting and adjusting the dosage because the usual dosage may increase myocardial O2 demand. This may cause angina and dysrhythmias. In a patient without side effects, the dose is increased at 4 to 6 week intervals as needed based on the TSH levels. It may take up to 8 weeks before the full effect of hormone therapy is seen. Levothyroxine has a peak of action of 1 to 3 weeks. It is important that the patient regularly take replacement medication. Lifelong thyroid therapy is usually required. Leotrix is a synthetic mix of levothyroxine T4 and leothyronine T3 in a 4-to-1 combination. Leotrix has a faster onset of action with a peak of 2 to 3 days. It can be used in acutely ill patients with hypothyroidism. Nursing management hypothyroidism. Nursing assessment. Careful assessment may reveal early and subtle changes in a patient suspected of having hypothyroidism. Note any history of hyperthyroidism and treat with anti-thyroid medications, RAI, or surgery. Ask the patient about using iodine-containing medications. Note any changes in appetite, weight, activity level, speech, memory, and skin, e.g., increased dryness or thickening. Assess for cold intolerance, constipation, and signs of depression. Further assessment should focus on heart rate, tenderness over the thyroid gland, and edema in the extremities and face. Nursing diagnoses. Nursing diagnoses for the patient with hypothyroidism may include activity intolerance, constipation, impaired nutritional status. Planning. The overall goals are that the patient with hypothyroidism will 1. Have relief of symptoms, 2. Maintain a euthyroid state, 3. Maintain a positive self-image, and 4. Adhere with lifelong thyroid therapy. Nursing implementation. Health promotion. Routine screening of thyroid function is not recommended in non-pregnant, asymptomatic adults. Risk factors include being female, white ethnicity, advancing age, or having type 1 diabetes. Down syndrome, family history of thyroid disease, goiter, previous hyperthyroidism, and external beam radiation in the head and neck area. High risk populations should be screened for subclinical thyroid disease. Acute care. Most people with hypothyroidism are treated on an outpatient basis. The person who develops myxedema coma needs acute nursing care, often in the ICU. Mechanical respiratory support and cardiac monitoring are often needed. Give thyroid hormone therapy and all other medications IV because severe gastric hypomotility may prevent the absorption of oral agents. Monitor the core temperature for hypothermia that often occurs in myxedema and myxedema coma. Use gentle soap and moisturize often to prevent skin breakdown. Frequent position changes and a low pressure mattress help maintain skin integrity. Monitor the patient's progress by assessing vital signs, body weight, fluid intake and output, and edema. Cardiac assessment is especially important because the cardiovascular response to hormone therapy determines the medication regimen. Note energy levels and mental alertness, which should improve within 2 to 14 days and continue a steady progression to normal levels. Neurologic status and TSH levels are used to determine continuing treatment. Ambulatory care. Patient teaching about medication management and identification of complications is essential. At first, the hypothyroid patient may have a hard time processing complex instructions. It is important to give written instructions, repeat the information often, and assess the patient's comprehension level. Stress the need for lifelong drug therapy and avoiding abruptly stopping drugs. Caution patients against doubling up on doses for any reason. Some patients notice weight loss and are tempted to increase dosing to achieve a desired weight. Teach the patient the expected and unexpected side effects, including the signs and symptoms of hypothyroidism and hyperthyroidism. The manifestations of overdose are the same as hyperthyroidism. Tell the patient to contact the HCP at once if symptoms such as orthopnea, dyspnea, rapid pulse, palpitations, chest pain, nervousness, or insomnia are present. The patient with diabetes should test blood glucose levels at least daily because the return to a euthyroid state often increases insulin requirements. Thyroid drugs increase the effects of anticoagulants and decrease the effects of digitalis compounds. Teach the patient the toxic signs and symptoms of these medications and the need to remain under close medical observation until stable. Medication interactions are an important reason for patients to consult the HCP before switching brands of thyroid replacement medication. Switching brands may change bioavailability of the drug and physiologic response. With treatment, striking transformations occur in both appearance and mental function. Most adults return to a normal state. Cardiovascular conditions and psychosis may persist despite corrections of the hormonal imbalance. Relapses occur if treatment is interrupted. Evaluation. The expected outcomes are that the patient with hypothyroidism will have relief of symptoms, maintain a euthyroid state with normal thyroid hormone and TSH levels, avoid complications of therapy, adhere to lifelong therapy. Thyroid nodules and cancer. A thyroid nodule, growth in the thyroid gland, may be benign or malignant thyroid cancer. More than 95% of all thyroid gland nodules are benign. Prevalence of thyroid nodule development increases with age. Benign nodules are usually not dangerous, but they can cause tracheal compression if they become too large. Thyroid cancer is the most common type of cancer of the endocrine system. An estimated 62,450 new cases of thyroid cancer are diagnosed annually. The incidence of thyroid cancer has increased significantly in the past 25 years. It is the most rapidly increasing cancer in the United States. Thyroid cancer affects more women, and the incidence is higher in whites and Asian Americans. Adults at risk include those who had head and neck radiation therapy during childhood, were exposed to radioactive fallout, or have a personal or family history of goiter. Types of thyroid cancer. The four main types of thyroid cancer are papillary, follicular, medullary, and anaplastic. Papillary thyroid cancer is the most common type, accounting for about 70 to 80% of all thyroid cancers. Papillary cancer tends to grow slowly. It initially spreads to lymph nodes in the neck. Follicular thyroid cancer makes up about 15% of all thyroid cancers. It tends to occur in older patients. Follicular cancer first metastasizes into the cervical lymph nodes and then spreads to the neck, lungs, and bones. Medullary thyroid cancer accounts for up to 10% of all thyroid cancers. It is more likely to occur in families and be associated with other endocrine problems. It is diagnosed by genetic testing for a proto-oncogene called RET. Medullary thyroid cancer is a type of multiple endocrine neoplasia. It is often poorly differentiated and associated with early metastasis. Anaplastic thyroid cancers occur in less than 2% of patients with thyroid cancer. It is the most advanced and aggressive thyroid cancer. The patient is least likely to respond to treatment and has a poor prognosis. Clinical manifestations and diagnostic studies. Primary manifestation of thyroid cancer is a painless, palpable nodule or nodules in an enlarged thyroid gland. Most nodules are found during routine palpation of the neck. The presence of firm, palpable cervical masses suggests lymph node metastasis. Some patients may have difficulty swallowing or breathing because of tumor growth invading the trachea or esophagus. Hemoptysis and airway obstruction may occur if the trachea is involved. Patients with thyroid cancer generally are euthyroid. Nodular enlargement of the thyroid gland or palpation of a mass requires further evaluation. Ultrasound is often the first test used. Follow-up testing may involve CT, MRI, positron emission tomography, PET, and ultrasound-guided fine needle aspiration, FNA. An FNA is done when a tissue sample for pathologic examination is needed. A thyroid scan may be done. The scan shows whether nodules on the thyroid are hot or cold. Hot tumors take up radioactive iodine. They're almost always benign. If the nodule does not take up the radioactive iodine, it appears as cold and has a higher risk for being cancer. Increases in serum calcitonin are associated with medullary thyroid cancer. In papillary and follicular cancers, serum thyroglobulin is high. In families with a history of medullary thyroid cancer, family members are encouraged to have genetic testing and thyroid screening on a regular basis. Interprofessional and nursing care. Surgical removal of the tumor is the main treatment for thyroid cancer. Surgical procedures range from unilateral total lobectomy to near total thyroidectomy, bilateral lobectomy. Lymph nodes in the neck may be removed to determine if the cancer has spread. RAI may be given to some patients to destroy any remaining cancer cells after surgery. RAI therapy improves survival rates in patients with papillary and follicular thyroid cancer. External beam radiation may be given as palliative treatment for patients with Metastatic thyroid cancer. Many thyroid cancers are TSH dependent. Thyroid hormone therapy in high doses is often prescribed to inhibit pituitary secretion of TSH. Chemotherapy, including doxorubicin, may be used for advanced disease. Vandetanib, Caprelsa, Lanvetinib, Lenvima, Sorafenib, Tosylate, Nexavar, and Cabozantinib, Cometriq, are targeted therapies for metastatic thyroid cancer. These drugs inhibit tyrosine kinases, enzymes that are involved in the growth of cancer cells. Nursing care for the patient with thyroid cancer is similar to that of a patient undergoing thyroidectomy. Because of the surgical site location and the potential for hypocalcemia, the patient needs frequent postoperative assessment. Assess the patient for airway obstruction, bleeding, and tetany, since the parathyroid gland may have been disturbed or removed during surgery. Multiple endocrine neoplasia. MEN is an inherited condition characterized by hormone-secreting tumors. It is caused by the mutation of one of two genes, MEN1 or RET, that normally control cell growth. Tumors may develop in childhood or later in life. The two major types of MEN are type 1 and type 2. Both types are often inherited as autosomal dominant disorders. Persons with type 1 often have parathyroid gland hyperactivity, hyperparathyroidism. Other signs may include hyperactivity of the pituitary gland, prolactinoma, and pancreas, gastrinoma. In most cases, the tumors are initially benign. Some tumors later become malignant. Persons with type 2 neoplasia often have medullary thyroid carcinoma. They may develop pheochromocytoma, tumor of the adrenal glands. Pheochromocytoma is discussed later. Treatment includes conservative management, watchful waiting, drugs to block the effects of excess hormone, and surgical removal of the gland and/or tumor. It is important for patients to have regular screening visits with the HCP so that new tumors may be detected early and existing tumors carefully monitored. Disorders of parathyroid glands. Hyperparathyroidism, etiology and pathophysiology. Hyperparathyroidism is a condition involving an increased secretion of parathyroid hormone, PTH. PTH helps regulate serum calcium and phosphate levels by stimulating bone resorption of calcium, renal tubular reabsorption of calcium, and activation of vitamin D. Thus, oversecretion of PTH is associated with increased serum calcium levels. Hyperparathyroidism is classified as primary, secondary, or tertiary. Primary hyperparathyroidism is due to an increased secretion of PTH leading to disorders of calcium, phosphate, and bone metabolism. The most common cause is a benign tumor, adenoma, in the parathyroid gland. Patients who have previously undergone head and neck radiation have an increased risk for developing a parathyroid adenoma. Long-term lithium therapy is also associated with primary hyperparathyroidism. Primary hyperparathyroidism affects 25 of 100,000 persons per year. The peak incidence is in the 40s and 50s. It affects twice as many women as men. Secondary hyperparathyroidism is a compensatory response to conditions that induce or cause hypocalcemia, the main stimulus of PTH secretion. These include vitamin D deficiencies, malabsorption, chronic kidney disease, and hyperphosphatemia. Tertiary hyperparathyroidism occurs when there is hyperplasia of the parathyroid glands and a loss of negative feedback from circulating calcium levels. Thus, there is autonomous secretion of PTH even with normal calcium levels. This condition is seen in patients who have had a kidney transplant after a long period of dialysis treatment for chronic kidney disease. Excess levels of PTH usually lead to hypercalcemia and hypophosphatemia. Multiple body systems are affected. Decreased bone density can occur because of the effect of PTH on osteoclastic bone resorption and osteoblastic bone formulation activity. The kidneys cannot reabsorb the excess calcium. This leads to increased urinary calcium levels, hypercalciuria. This urinary calcium, along with a large amount of urinary phosphate, can lead to stone formation. Clinical manifestations and complications. Manifestations range from an asymptomatic person diagnosed through testing for unrelated problems to a patient with overt symptoms. The manifestations are associated with hypercalcemia, loss of appetite, constipation, fatigue, emotional disorders, shortened attention span, and muscle weakness, particularly in the proximal muscles of the lower extremities, often occur. Complications include osteoporosis, renal failure, kidney stones, pancreatitis, cardiac changes, and long bone, rib, and vertebral fractures. Diagnostic studies. PTH levels are increased in patients with hyperparathyroidism. Serum calcium levels usually exceed 10 milligrams per deciliter. Because of its inverse relation with calcium, the serum phosphorus level is usually less than 3 milligrams per deciliter. Hypercalcemia in asymptomatic cases is often identified through a routine chemistry panel. Increases in other laboratory tests include urine calcium, serum chloride, uric acid, creatinine, amylase if pancreatitis is present, and alkaline phosphatase in the presence of bone disease. Bone density measurements may be used to detect bone loss. Conversely, those with bone loss on a screening dual energy X-ray absorptiometry DEXA scan should be tested for hypercalcemia. MRI, CT, and/or ultrasound can detect an adenoma. Intraprofessional care. The goal of treatment is to relieve symptoms and prevent complications caused by excess PTH. The choice of therapy depends on the urgency of the situation, degree of hypercalcemia, and underlying cause of the disorder. Surgical therapy. The most effective treatment of primary and secondary hyperparathyroidism is surgical intervention. Surgery involves partial or complete removal of the parathyroid glands. The most common procedure involves endoscopy and is done on an outpatient basis. Criteria for surgery include increased serum calcium levels more than 1 milligram per deciliter above the upper limit of normal, hypercalciuria greater than 400 milligrams per day, markedly reduced bone mineral density, overt symptoms, e.g. neuromuscular effects, kidney stones, or age under 50 years. Parathyroidectomy leads to a rapid reduction of high calcium levels. Patients who have multiple parathyroid glands removed may undergo autotransplantation of normal parathyroid tissue in the forearm or near the sternocleidomastoid muscle. This allows PTH secretion to continue with normalization of calcium levels. If autotransplantation is not possible, or if it fails, the patient will need to take calcium supplements for life. Non-surgical therapy. A conservative approach is often used in patients who are asymptomatic or have mild symptoms of hyperparathyroidism. Ongoing care includes regular examination with measurements of serum PTH, calcium, phosphorus, alkaline phosphatase, creatinine, and blood urea nitrogen (BUN) to assess renal function, and urinary calcium excretion. Annual X-rays and DEXA scans assess for metabolic bone loss. Continued ambulation and avoiding immobility are important. Dietary measures include high fluid and moderate calcium intake. Severe hypercalcemia is managed with IV sodium chloride solution and loop diuretics, such as furosemide, to increase the urinary excretion of calcium. Several drugs help to lower calcium levels, but they do not treat the underlying problem. Bisphosphonates, e.g., alendronate, Fosamax, inhibit osteoclastic bone resorption, normalizing serum calcium levels and improving bone mineral density. IV bisphosphonates, e.g., pamidronate, Iridia, can rapidly lower serum calcium in patients with dangerously high levels. Phosphates are given if the patient has normal renal function and low serum phosphate levels. Calcimimetic agents, e.g., cinacalcet, Sensipar, increase the sensitivity of the calcium receptor on the parathyroid gland, resulting in decreased PTH secretion and calcium blood levels. They are useful in treating secondary hyperparathyroidism in those with chronic kidney disease on dialysis or in patients with parathyroid cancer. Nursing management. Hyperparathyroidism. Nursing care for the patient after a parathyroidectomy is similar to that for a patient after a thyroidectomy. The major complications are associated with hemorrhage and fluid and electrolyte problems. Tetany, a condition of neuromuscular hyperexcitability associated with sudden decrease in calcium levels, is another concern. It is usually apparent early in the postoperative period, but may develop over several days. Mild tetany, characterized by unpleasant tingling of the hands and around the mouth, may be present but should decrease over time. If tetany becomes more severe, e.g., muscular spasms, laryngospasms, IV calcium may be given. IV calcium gluconate should be readily available for patients after parathyroidectomy in case acute tetany occurs. Monitor intake and output to evaluate the patient's fluid status. Assess calcium, potassium, phosphate, and magnesium levels frequently, as well as Chavostex and Trousseau's signs. Encourage mobility to promote bone calcification. If surgery is not done, treatment to relieve symptoms and prevent complications is started. Help the patient to adapt the meal plan to their lifestyle. A referral to a dietitian may be useful. Because immobility can worsen bone loss, emphasize the importance of an exercise program. Encourage the patient to keep the regular follow-up appointments. Teach the patient the symptoms of hypocalcemia and hypercalcemia and to report them if they occur. Hypocalcemia and hypercalcemia are discussed in Chapter 16. Hypoparathyroidism. Hypoparathyroidism is an uncommon condition associated with inadequate circulating PTH. It is characterized by hypocalcemia due to a lack of PTH to maintain serum calcium levels. PTH resistance at the cellular level may also occur. Pseudo-hypoparathyroidism. This is caused by a genetic defect resulting in hypocalcemia despite normal or high PTH levels. It is often associated with hypothyroidism and hypogonadism. The most common cause is iatrogenic. This may include accidental removal of the parathyroid glands or damage to the vascular supply of the glands during neck surgery, e.g., thyroidectomy. Idiopathic hypoparathyroidism resulting from the absence, fatty replacement, or atrophy of the glands, is a rare disease. It usually occurs early in life and may be associated with other endocrine disorders. Affected patients may have antiparathyroid antibodies, severe hypomagnesemia, e.g., malnutrition, chronic alcoholism, renal failure, can suppress PTH secretion. Other causes of parathyroid deficiency include tumors and heavy metal poisoning. The features of acute hypoparathyroidism are due to hypocalcemia. Sudden decreases in calcium concentration cause tetany, characterized by tingling of the lips and stiffness in the extremities. Painful tonic spasms of smooth and skeletal muscles can cause dysphagia and laryngospasms, which compromise breathing. Lethargy, anxiety, and personality changes may occur. Abnormal laboratory findings include decreased serum calcium and PTH levels and increased serum phosphate levels. Interprofessional and nursing care. Treatment goals are to treat acute complications such as tetany, maintain normal serum calcium levels, and prevent long-term complications. Emergency treatment of tetany after surgery requires IV calcium administration. Give IV calcium slowly. Use ECG monitoring when giving calcium because high serum calcium levels can cause hypotension, serious dysrhythmias, or cardiac arrest. The patient who takes digoxin is particularly vulnerable. It is important to assess IV patency before administration. Calcium chloride can cause venous irritation and inflammation. Extravasation may cause cellulitis, necrosis, and tissue sloughing. Rebreathing may partially relieve acute neuromuscular symptoms associated with hypocalcemia, including muscle cramps and mild tetany. Have the patient breathe in and out of a paper bag or breathing mask. This reduces CO2 excretion from the lungs, increases carbonic acid levels in the blood, and lowers the pH. A lower pH acidic environment enhances calcium ionization, which causes more total body calcium to be available in the active form. Teach the patient how to manage long-term drug and nutritional therapy. PTH replacement is not recommended because of the expense and need for parenteral administration. Most patients receive oral calcium supplements, magnesium supplements, and vitamin D. Vitamin D is used to enhance intestinal calcium absorption. Vitamin D, calcitriol, increases calcium levels rapidly and is quickly metabolized. Rapid metabolism is desired because vitamin D is a fat-soluble vitamin, and toxicity can cause irreversible renal impairment. A high-calcium meal plan includes foods such as dark green vegetables, soybeans, and tofu. Tell the patient to avoid foods containing oxalic acid, e.g., spinach, rhubarb, because they inhibit calcium absorption. Teach the patient about the need for follow-up care, including monitoring of calcium levels 3 or 4 times a year. Disorders of adrenal cortex. Adrenal cortex steroid hormones have 3 main classifications: glucocorticoids, mineralocorticoids, and androgens. Glucocorticoids regulate metabolism, increase blood glucose levels, and are critical in the physiologic stress response. The primary glucocorticoid is cortisol. Mineralocorticoids regulate sodium and potassium balance. The primary mineralocorticoid is aldosterone. Androgens contribute to growth and development in both genders and to sexual development in men. The term corticosteroid refers to any of these 3 types of hormones made by the adrenal cortex. Cushing syndrome, etiology and pathophysiology. Cushing syndrome is a clinical condition that results from chronic exposure to excess corticosteroids, particularly glucocorticoids. Several conditions can cause Cushing syndrome. The most common cause is iatrogenic administration of exogenous corticosteroids, e.g., prednisone. About 85% of the cases of endogenous Cushing syndrome are due to an ACTH secreting pituitary adenoma, Cushing disease. Less common causes include adrenal tumors and ectopic ACTH production by tumors, usually of the lung or pancreas, outside of the hypothalamic pituitary adrenal axis. Cushing disease and primary adrenal tumors are more common in women in the 20 to 40-year-old age group. Ectopic ACTH production is more common in men. Clinical manifestations. Manifestations occur in most body systems and are related to excess levels of corticosteroids. Although signs of glucocorticoid excess usually predominate, symptoms of mineralocorticoid and androgen excess can occur. Corticosteroid excess causes pronounced changes in physical appearance. Weight gain is the most common feature. It results from the accumulation of adipose tissue in the trunk. Centripetal obesity. Face, moon face, and cervical areas, buffalo hump. Hyperglycemia occurs because of glucose intolerance associated with cortisol-induced insulin resistance and increased gluconeogenesis by the liver. Muscle wasting causes weakness, especially in the extremities. A loss of bone matrix leads to osteoporosis and back pain. The loss of collagen makes the skin weaker, thinner, and more easily bruised. Purplish red striae, usually depressed below the skin surface, appear on the abdomen, breast, or buttocks. Catabolic processes lead to a delay in wound healing. Mineralocorticoid excess may cause hypokalemia from potassium excretion and hypertension from fluid retention. Adrenal androgen excess may cause severe acne, the development of male characteristics in women, and feminization in men. Menstrual disorders and hirsutism in women and gynecomastia and impotence in men are seen more often in adrenal cancers. Diagnostic studies. Diagnosing Cushing syndrome begins with confirming increased plasma cortisol levels. We use 3 tests. 1. Midnight or late-night salivary cortisol. 2. Low-dose dexamethasone suppression test. And 3. 24-hour urine cortisol. Urine cortisol levels higher than 100 micrograms per 24 hours indicate Cushing syndrome. Urine levels of 17 ketosteroids may be high. A CT scan or MRI of the pituitary and adrenal glands can detect a tumor. Plasma ACTH levels may be low, normal, or high, depending on the underlying cause of Cushing syndrome. High or normal ACTH levels indicate Cushing disease, while low or undetectable levels indicate an adrenal or medication cause. Other findings associated with but not diagnostic of Cushing syndrome include leukocytosis, lymphopenia, eosinopenia, hyperglycemia, glycosuria, hypercalciuria, and osteoporosis. Hypokalemia and alkalosis are seen in an ectopic ACTH syndrome and adrenal cancer. Interprofessional care. The primary goal of treatment is to normalize hormone secretion. The specific treatment depends on the underlying cause. If the underlying cause is a pituitary adenoma, the standard treatment is surgical removal of the pituitary tumor using the transsphenoidal approach. Radiation therapy is an option for patients who are not good surgical candidates. An adrenalectomy is done if Cushing syndrome is caused by adrenal tumors or hyperplasia. Sometimes bilateral adrenalectomy is needed. A laparoscopic approach is used unless a malignant adrenal tumor is suspected. An open surgical adrenalectomy is usually done for adrenal cancer. Patients with ectopic ACTH secreting tumors are best managed by removing the tumor, usually lung or pancreas. This is usually possible when the tumor is benign. If a cancerous tumor has already metastasized, surgical removal may not be possible or successful. When the patient is a poor candidate for surgery or prior surgery has failed, drug therapy may be tried. The goal of drug therapy is to suppress the synthesis and secretion of cortisol from the adrenal gland, medical adrenalectomy. Drugs used include ketoconazole and mitotane. These are used cautiously because they are often toxic at the dosages needed to reduce cortisol secretion. Hydrocortisone or prednisone may be needed to avoid adrenal insufficiency. Mifepristone, Korlim, may be used to control hyperglycemia in patients with endogenous Cushing syndrome who have type 2 diabetes. If Cushing syndrome developed because of prolonged use of corticosteroids, e.g. prednisone, the following alternatives may be tried. 1. Gradually discontinuing corticosteroid therapy. 2. Reducing the corticosteroid dose. And 3. Converting to alternate day dosing. Gradual tapering of the corticosteroids is necessary to avoid potentially life-threatening adrenal insufficiency. In alternate day dosing, twice the daily dosage of a shorter-acting corticosteroid is given every other morning to minimize hypothalamic pituitary adrenal suppression, growth suppression, and altered appearance. The plan is not used when the corticosteroids are given as hormone therapy. Nursing management, Cushing syndrome. Nursing diagnoses. Nursing diagnoses for the patient with Cushing syndrome may include risk for infection, impaired nutritional status, disturbed body image, impaired tissue integrity. Planning. The overall goals are that the patient with Cushing syndrome will 1. Have relief of symptoms, 2. Avoid serious complications, 3. Maintain a positive self-image, and 4. Actively take part in the therapeutic plan. Nursing implementation. Health promotion. Health promotion focuses on identifying patients at risk for Cushing syndrome. Patients receiving long-term exogenous corticosteroids are at risk. Teaching related to using medications and monitoring side effects is an important preventative measure. Acute care. The patient with Cushing syndrome is seriously ill. Because the therapy has many side effects, assessment focuses on signs and symptoms of hormone and drug toxicity and complicating conditions, e.g. CVD, diabetes, infection. Monitor vital signs, daily weight, and glucose. Assess for infection. Because signs and symptoms of inflammation, e.g. fever, redness, may be minimal or absent. Assess for pain, loss of function, and purulent drainage. Monitor for signs and symptoms of thromboembolic events, such as pulmonary emboli, e.g. sudden chest pain, dyspnea, tachypnea. Another important focus of nursing care is emotional support. Changes in appearance, such as truncal obesity, multiple bruises, hirsutism in women, and gynecomastia in men, can be distressing. The patient may feel unattractive, repulsive, or unwanted. You can help by being sensitive to the patient's feelings and offering respect and unconditional acceptance. Reassure the patient that the physical changes and much of the emotional lability will resolve when hormone levels return to normal. If treatment involves surgical removal of a pituitary adenoma, an adrenal tumor, or one or both adrenal glands, nursing care will include preoperative and postoperative care. Preoperative care. Before surgery, the patient should be brought to optimal physical condition. Hypertension and hyperglycemia must be controlled. Hypokalemia must be corrected with diet and potassium supplements. A high-protein diet helps correct the protein depletion. Preoperative teaching depends on the type of surgical approach planned. Hypophysectomy or adrenalectomy. Include information about the expected care after surgery. Postoperative care. Surgery of the adrenal glands poses great risks. Because the adrenal glands are vascular, the risk for hemorrhage is increased. After both laparoscopic and open adrenalectomy, the patient may have a nasogastric tube, a urinary catheter, IV therapy, and central venous pressure monitoring. Initiate VTE prophylaxis. Manipulating glandular tissue during surgery may release large amounts of hormones into the circulation. This can produce marked fluctuations in the metabolic processes affected by these hormones. After surgery, BP, fluid balance, and electrolyte levels may be unstable due to the hormone fluctuations. High doses of corticosteroids, e.g., hydrocortisone, are given IV during surgery and for several days afterward to ensure adequate responses to the stress of the procedure. If large amounts of endogenous hormone were released into the systemic circulation during surgery, the patient is likely to develop hypertension, increasing the risk for hemorrhage. High corticosteroid levels cause problems with glycemic control, increase risk for infection, and delay wound healing. The critical period for circulatory instability is 24 to 48 hours after surgery. During this time, you must constantly be alert for signs of corticosteroid imbalance. Report any rapid or significant changes in BP, respirations, or heart rate. Monitor fluid intake and output carefully and assess for potential imbalances. IV corticosteroids are given, and the dosage and flow rate are adjusted to the patient's manifestations in fluid and electrolyte balance. Oral doses are given as tolerated. After IV corticosteroids are withdrawn, keep the IV line open for quick administration of corticosteroids or vasopressors. Obtain morning urine samples at the same time each morning for a cortisol measurement to evaluate the surgery's effectiveness. If corticosteroid dosage is tapered too rapidly after surgery, acute adrenal insufficiency may develop. Vomiting, increased weakness, dehydration, and hypotension are signs of hypocortisolism. The patient may have painful joints, pruritus, or peeling skin, and may have severe emotional problems. Report these signs and symptoms so that the drug doses can be adjusted as needed. The patient is usually kept on bed rest until the BP stabilizes. Be alert for subtle signs of infection, because the usual inflammatory responses are suppressed. To prevent infection, provide meticulous care when changing the dressing and during any other procedures that involve access to body cavities, circulation, or areas under the skin. Ambulatory care. Discharge instructions are based on the patient's lack of endogenous corticosteroids and resulting inability to react physiologically to stressors. Consider a home health nurse referral, especially for older adults, because of the need for ongoing evaluation and teaching. Teach the patient to always wear a medical alert bracelet and carry medical identification and instructions in a wallet or purse. Teach the patient to avoid exposure to extreme temperatures, infections, and emotional situations. Stress may cause acute adrenal insufficiency because the remaining adrenal tissue cannot meet an increased hormonal demand. Teach patients to adjust their corticosteroid replacement therapy by their stress levels. Consult with the patient's HCP to determine the parameters for dosage changes if this plan is feasible. If the patient cannot adjust their own medication, or if weakness, fainting, fever, or nausea and vomiting occur, the patient should contact the HCP for a possible adjustment in corticosteroid dosage. Many patients require lifetime replacement therapy. However, patients should be prepared for it to take several months to adjust the hormone dose satisfactorily. Evaluation. The expected outcomes are that the patient with Cushing syndrome will have no signs or symptoms of infection, maintain weight appropriate for height, state acceptance of appearance and treatment plan, show healing of skin, and maintaining intact skin. Adrenocortical insufficiency, etiology and pathophysiology. Adrenocortical insufficiency, hypofunction of the adrenal cortex, may be from a primary cause, Addison's disease, or a secondary cause, lack of pituitary ACTH secretion. In Addison's disease, all three classes of adrenal corticosteroids, glucocorticoids, mineralocorticoids, and androgens, are reduced. In secondary adrenocortical insufficiency, corticosteroids and androgens are deficient, but mineralocorticoids rarely are. ACTH deficiency may be caused by pituitary disease or suppression of the hypothalamic pituitary axis because of the use of exogenous corticosteroids. Up to 80% of Addison's disease cases in the United States are caused by an autoimmune response. Autoimmune adrenalitis causes the adrenal cortex to be destroyed by antibodies. This results in loss of glucocorticoid, mineralocorticoid, and adrenal androgen hormones. Addison's disease can be present along with other endocrine conditions. This is known as autoimmune polyglandular syndrome. It is most common in white females. Those with autoimmune adrenalitis often have other autoimmune disorders such as type 1 diabetes, autoimmune thyroid disease, pernicious anemia, and celiac disease. Although tuberculosis causes Addison's disease worldwide, it is now an uncommon cause in the United States. Other causes include amyloidosis, fungal infections, e.g., histoplasmosis, AIDS, and metastatic cancer. Iatrogenic Addison's disease may be due to adrenal hemorrhage, often related to anticoagulant therapy, chemotherapy, ketoconazole therapy for AIDS, or bilateral adrenalectomy. Adrenal insufficiency most often occurs in adults younger than 60 years of age and affects both genders equally. Clinical manifestations. Because manifestations do not tend to become evident until 90% of the adrenal cortex is destroyed, the disease is often advanced before it is diagnosed. The manifestations have a slow, insidious onset and include anorexia, nausea, progressive weakness, fatigue, and weight loss. Increased ACTH causes the striking feature of a bronze-colored skin, hyperpigmentation. It is seen mainly in sun-exposed areas of the body, at pressure points over joints, and in the creases, especially palmar creases. The changes in the skin are likely due to increased secretion of B-lipoprotein, which contains melanocyte-stimulating hormone, MSH. MSH is increased because of decreased negative feedback and subsequent low corticosteroid levels. Other manifestations include abdominal pain, diarrhea, headache, orthostatic hypotension, salt craving, and joint pain. Irritability and depression may occur in primary adrenal hypofunction. Patients with secondary adrenocortical hypofunction may have many signs and symptoms similar to those of patients with Addison's disease. However, they usually do not have hyperpigmented skin because ACTH levels are low. Complications. Patients with adrenocortical insufficiency are at risk for acute adrenal insufficiency. Addisonian crisis. It is a life-threatening emergency caused by insufficient adrenocortical hormones or a sudden sharp decrease in these hormones. Addisonian crisis is triggered by 1. Stress, e.g. from infection, surgery, psychologic distress. 2. The sudden withdrawal of corticosteroid hormone therapy. 3. Adrenal surgery. Or 4. Sudden pituitary gland destruction. During acute adrenal insufficiency, the patient has severe manifestations of glucocorticoid and mineralocorticoid deficiencies. These include hypotension, tachycardia, dehydration, hyponatremia, hyperkalemia, hypoglycemia, fever, weakness, and confusion. Hypotension may lead to shock. Circulatory collapse associated with adrenal insufficiency is often unresponsive to the usual treatment. Vasopressors and fluid replacement. GI manifestations include severe vomiting, diarrhea, and pain in the abdomen. Pain may occur in the lower back and legs. Diagnostic studies. The ACTH stimulation test is a common test to diagnose adrenal insufficiency. Baseline cortisol and ACTH levels are measured, and the patient is given an IV injection of synthetic ACTH, cosyntropin. Cortisol and ACTH levels are rechecked after 30 and 60 minutes. The normal response is a rise in blood cortisol levels. People with Addison's disease have little or no increase in cortisol levels. Those with primary adrenal insufficiency have a high ACTH level. When the response to the ACTH test is abnormal, a corticotropin-releasing hormone CRH stimulation test may be done. The patient is given an IV injection of synthetic CRH, and blood is taken after 30 and 60 minutes. Those with Addison's disease have high ACTH levels, but no cortisol. People with secondary adrenal insufficiency from pituitary or hypothalamus problems do not make ACTH or have a delayed response. Other abnormal laboratory findings may include hyperkalemia, hypochloremia, hyponatremia, hypoglycemia, anemia, and increased BUN levels. An ECG may show low voltage and peaked T waves caused by hyperkalemia. CT scans and MRI can identify other causes, including tumors, fungal infections, tuberculosis, or adrenal calcification. Interprofessional and nursing care. Treatment focuses on managing the underlying cause when possible. The mainstay is often lifelong hormone therapy with glucocorticoids and mineralocorticoids. Overall, patients who take their medications consistently can expect a normal life expectancy. Hydrocortisone, the most common form of hormone therapy, has both glucocorticoid and mineralocorticoid properties. Mineralocorticoids are replaced with fludrocortisone. Women need androgen replacement with dehydroepiandrosterone (DHEA), as their only source of androgen production is the adrenal glands. Increased salt is added to the diet. As a nurse, you have a key role in the long-term management of Addison's disease. The serious nature of the disease and the need for lifelong hormone therapy necessitate a comprehensive teaching plan. Glucocorticoids are usually given in divided doses, 2/3 in the morning and 1/3 in the afternoon. Mineralocorticoids are given once daily, preferably in the morning. This schedule reflects normal circadian rhythm in endogenous hormone secretion and decreases the side effects associated with corticosteroid therapy. Teach patients using mineralocorticoid therapy, fludrocortisone, how to take their BP, increase salt intake, and report any significant changes to the HCP. The patient with Addison's disease needs an increased dosage of corticosteroids in stressful situations to prevent Addisonian crisis. Examples of situations requiring corticosteroid adjustment are fever, influenza, tooth extraction, and rigorous physical activity, such as playing sports on a hot day or distance running. Provide written and verbal instructions on when to change the dose. Review stress management techniques. If vomiting or diarrhea occurs, as may happen with gastroenteritis, the patient should notify the HCP at once. Electrolyte replacement and parenteral administration of cortisol may be needed. Teach patients the signs and symptoms of corticosteroid deficiency and excess, Cushing syndrome, and to report these signs to the HCP so that the drug dose can be adjusted. It is critical that the patient wear an identification bracelet and carry a wallet card saying the patient has Addison's disease, so that appropriate therapy can be started in case of an emergency. The patient should always carry an emergency kit with 100 milligrams of IM hydrocortisone and syringes. Teach the patient and caregiver how to give an IM injection. When the patient with Addison's disease is hospitalized, nursing management focuses on monitoring the patient while correcting fluid and electrolyte balance. Assess vital signs and neurologic status. Monitor for signs of fluid volume deficit and electrolyte imbalance. Obtain a daily weight and keep an accurate intake and output record. Take a complete medication history to determine drugs that could potentially interact with corticosteroids. These drugs include oral hypoglycemics, cardiac glycosides, oral contraceptives, anticoagulants, and NSAIDs. Note changes in BP, weight gain, weakness, or other manifestations of Cushing syndrome. Guard the patient against exposure to infection and help with daily hygiene. Protect the patient from noise, light, and environmental temperature extremes. The patient cannot cope with these stresses because of the inability to make corticosteroids. Addisonian crisis is a life-threatening emergency requiring aggressive management. Treatment is directed towards shock management and high-dose hydrocortisone replacement. Large volumes of 0.9 saline solution and 5% dextrose are given to reverse hypotension and electrolyte imbalances until BP returns to normal. Corticosteroid therapy. Corticosteroids are effective in treating many diseases and disorders. However, the long-term administration of corticosteroids at therapeutic doses often leads to serious complications and side effects. For this reason, corticosteroid therapy is not recommended for minor chronic conditions. Therapy should be reserved for diseases that have a risk for death or permanent loss of function, and for conditions in which short-term therapy is likely to produce remission or recovery. The potential benefits of treatment must always be weighed against the risks. Patients receive corticosteroid therapy for many reasons. Detailed instruction is needed to ensure patient adherence. When corticosteroids are used as non-replacement therapy, they are taken once daily or once every other day. They should be taken early in the morning with food to decrease gastric irritation. Because exogenous corticosteroid use may suppress endogenous ACTH and therefore endogenous cortisol, suppression is time and dose dependent. Emphasize the danger of abruptly stopping corticosteroid therapy to patients and caregivers. Corticosteroids taken for longer than 1 week will suppress adrenal production, and oral corticosteroids must be tapered. Ensure that increased doses of corticosteroids are prescribed in acute care or home care settings in situations of physical or emotional stress. Corticosteroid-induced osteoporosis is an important concern for patients who receive corticosteroid treatment for prolonged periods, longer than 3 months. Therapies to reduce bone resorption include increased calcium intake, vitamin D supplementation, biphosphonates, e.g. alendronate, and a low-impact exercise program. Further instruction and interventions to minimize the side effects and complications of corticosteroid therapy are outlined in table blah 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 blah. Hyperaldosteronism. Hyperaldosteronism, Conn's syndrome, is characterized by excess aldosterone secretion. The main effects of aldosterone are 1. Sodium retention and 2. Potassium and hydrogen ion excretion. Thus, the hallmark of this disease is hypertension with hypokalemic alkalosis. Primary hyperaldosteronism, PA, is most often caused by a small, solitary adrenocortical adenoma. Sometimes multiple lesions are involved and are associated with bilateral adrenal hyperplasia. PA affects women more than men, and it usually occurs between 30 and 50 years of age. A genetic link has been found in some patients. PA causes up to 2% of all cases of hypertension. Secondary hyperaldosteronism occurs in response to a non-adrenal cause of increased aldosterone levels, such as renal artery stenosis, renin-secreting tumors, and chronic kidney disease. Increased aldosterone levels are associated with sodium retention and potassium excretion. Sodium retention leads to hypernatremia, hypertension, and headache. Edema does not usually occur because the rate of sodium excretion increases, preventing more severe sodium retention. Potassium wasting leads to hypokalemia, which causes generalized muscle weakness, fatigue, dysrhythmias, glucose intolerance, and metabolic alkalosis that may lead to tetany. Hyperaldosteronism should be suspected in hypertensive patients with hypokalemia who are not being treated with diuretics. PA is associated with increased plasma aldosterone levels, increased sodium levels, decreased serum potassium levels, and decreased plasma renin activity. A CT scan or MRI can detect an adenoma. If a tumor is not found, plasma 18 hydroxycorticosterone is measured after overnight bed rest. A level greater than 50 nanograms per deciliter indicates an adenoma. Interprofessional and nursing care. The preferred treatment for PA is surgical removal of the adenoma, adrenalectomy. A laparoscopic approach is most often used. Before surgery, patients should be treated with potassium-sparing diuretics, e.g. spironolactone, eplerenone, Inspira, and antihypertensive agents to normalize serum potassium levels and BP. Spironolactone and allopurinol block the binding of aldosterone to the mineralocorticoid receptor in the terminal distal tubules and collecting ducts of the kidney, thus increasing sodium and water excretion and potassium retention. Oral potassium supplements and sodium restrictions may be needed. However, potassium supplementation and a potassium-sparing diuretic should not be started simultaneously because of the risk for hyperkalemia. Teach patients taking eplerenone to avoid grapefruit juice, as it may increase potential for hyperkalemia. Patients with bilateral adrenal hyperplasia are treated with a potassium-sparing diuretic. Calcium channel blockers may be used to control BP. Dexamethasone may be used to decrease adrenal hyperplasia. Nursing care includes careful assessment of fluid and electrolyte balance, especially potassium, and cardiovascular status. Monitor BP frequently before and after surgery because unilateral adrenalectomy is successful in controlling hypertension in only 80% of patients with an adenoma. Tell patients receiving spironolactone about the possible side effects of gynecomastia, impotence, and menstrual disorders, as well as the signs and symptoms of hypokalemia and hyperkalemia. Teach patients how to monitor their own BP and the need for frequent monitoring. Stress the need for continued health supervision. Pheochromocytoma. Pheochromocytoma is a rare condition caused by a tumor in the adrenal medulla. It affects the chromaffin cells, resulting in an excess production of catecholamines, epinephrine, norepinephrine. The most dangerous immediate effect of the disease is severe hypertension. If left untreated, it may lead to encephalopathy, diabetes, cardiomyopathy, multiple organ failure, and death. It most often occurs in young to middle-aged adults. Pheochromocytoma may be inherited in persons with MEN. The most striking findings are severe episodic hypertension accompanied by severe pounding headache, tachycardia with palpitations, profuse sweating, and unexplained abdominal or chest pain. Attacks can be induced by direct trauma, mechanical pressure to the tumor, stress, e.g. surgery, exercise, defecation, sexual intercourse, alcohol consumption, smoking, or many drugs including antihypertensive, opioids, radiologic contrast media, and tricyclic antidepressants. Attacks can last for a few minutes to several hours. The simplest and most reliable diagnostic test is measurement of urinary fractioned metanephrines, catecholamine metabolites, and fractioned catecholamines and creatinine, usually done as a 24-hour urine collection. Values are increased in at least 95% of persons with pheochromocytoma. Serum catecholamines may be increased during an attack. CT scans and MRI can detect tumors. Do not palpate the abdomen of a patient with suspected pheochromocytoma. It might cause the sudden release of catecholamines and severe hypertension. Interprofessional and nursing care. The main treatment is surgical removal of the tumor. Treatment with alpha and beta adrenergic receptor blockers is required before surgery to control BP and prevent an intraoperative hypertensive crisis. Therapy begins with an alpha adrenergic receptor blocker, e.g. doxazosin, prazosin, phenozibenzamine, 10 to 14 days before surgery to reduce BP. After adequate alpha adrenergic blockade, beta adrenergic receptor blockers, e.g. propranolol, are used to decrease tachycardia and dysrhythmias. Beta blockers are started too early. Unopposed alpha adrenergic stimulation can precipitate a hypertensive crisis. Therapy can cause orthostatic hypotension. Teach the patient to make postural changes cautiously. Surgery is usually done using a laparoscopic approach. Removing the adrenal tumor often cures the hypertension, but hypertension persists in about 10 to 30% of patients. If surgery is not an option, metyrosine Demser can decrease catecholamine production by the tumor. Case finding is an important nursing role. Although pheochromocytoma is associated with several symptoms, the diagnosis is often missed. Any patient with hypertension accompanied by symptoms of Sympathoadrenal stimulation should be referred to an HCP for definitive diagnosis. Assess the patient for the classic triad of symptoms of pheochromocytoma: severe pounding headache, tachycardia, and profuse sweating. Monitor the BP often if the patient is having an attack. Make the patient as comfortable as possible. Monitor blood glucose levels to assess for diabetes. Patients need rest, nourishing food, and emotional support during this period. Surgical care is similar to that for any patient undergoing adrenalectomy. Note that BP fluctuations from catecholamine excesses tend to be severe and must be carefully monitored. Emphasize the importance of follow-up and routine BP monitoring because hypertension may persist even when the tumor is removed.